I represent District 25, which is mostly Rochester, which is the third largest city in Minnesota. I am an assistant majority leader. I have served in the Senate. This is my first term in the Senate. I'm 2 years in, halfway through. And prior to this, I served one term in the Minnesota House. My work outside of the legislature, we are a part-time legislature. So my work when I'm not, legislating is in healthcare. I'm a registered nurse and I have been for 22 years. And so this issue, this topic is near and dear to my heart for a number of reasons. I'm really excited to talk about it with you all. So you can advance to the next slide there. Just very briefly, a little bit more about myself. My committee assignments, I serve on Health and Human Services. I have throughout my entire legislative career. I also serve on Housing and Homelessness Prevention. I serve as the vice chair of that committee. I also serve on Elections, Education Policy, and Transportation. So you can go to the next slide there. So I'm going to talk about the Debt Fairness Act, as was mentioned. And this was a bill that I was really grateful to work on last session in partnership with the Attorney General's office and my partner, Representative Liz Ryer in the House. And if you could flip to the next slide, that would be great. So this was really, this bill came out of partnership with the AG's office. In hearing, their office heard from thousands of Minnesotans the challenges around medical debt. And as we heard in the intro, and you all know very well, I'm sure, really the significant issue medical debt is for so many people. And there's lots of reasons for that. And I want to be clear that this legislation doesn't solve all of that. It does not, this is not the end all be all. But it will make a significant difference for Minnesotans who are affected by medical debt. Medical debt is not like other debt. For folks who take out a business loan or a car loan or other types of debt, it's a planned thing that they make a choice to do that. Medical debt is not that way. None of us plan on needing an emergency surgery or, an appendectomy or having a car crash or a diagnosis. Any one of us could be an accident or a diagnosis away from having significant medical debt. It's not something we choose. It's something that happens, and largely because of a harmful healthcare system that we have these high costs, and there's lots of other policies that we are working on to improve that. But the reality, the fact of medical debt impacts people's lives significantly. And so we heard those stories. The Attorney General's office heard those stories. I hear those stories every day that I work in a hospital taking care of patients. And so often in talking to my patients, and their family members, they cannot focus on their healing and recovery because they are overwhelmed by what they anticipate is coming in terms of the bill. And so looking at ways that we can make a difference in those people's lives was the genesis of this package bill. And part of it is around medical debt. And there's another section that I won't get into the details of that is around consumer debt protections. And they really go hand in hand, but I'm going to focus on the medical debt portions today. There are three key pieces, the biggest pieces that are listed here that I'll talk about, and then some other details I'll mention as well. The first big thing is that it bans healthcare facilities from denying care to patients and family members solely because they owe them a debt. And, on its face, that sounds like, of course, were there really places that were doing that? Absolutely, there were. We heard really heartbreaking stories. The one that sticks in my mind was a mother of a young boy who had a rare eye disease. He needed care, he needed surgery. The trajectory of that disease is that he was going to go blind if left untreated. And there, was one entity in our state that, because it was a rare disease, that could provide that specialized care. and it was expensive, and they struggled with the bills, and they got to a point where they had a debt. They carried that medical debt, and their care was cut off. They were not able to make an appointment to get care for their son, which again eventually would have meant he would have gone blind. And so the Attorney General stepped in, and it ended up being okay. But there are many cases like that across the state where people were being denied care solely because they owed money to a facility. And I want to be clear, if people owe a debt, they should pay it. However, the system should be fair, and we shouldn't be pushing people into poverty just because of a medical debt. And so really, this act is intended to add some fairness into that system. And so doesn't allow that denial of care. The second thing is that it bans reporting of medical debt to credit bureaus. And as was mentioned at the federal level, this is now being looked into as well, which is great. But this has already been enacted in Minnesota. And that is important, not only just on its face, but that credit score impacts people, many things in people's lives, their ability to get housing, their rates for car insurance, their rates for a number of bills in their life. And so it makes a big difference for people. And so not having that, again, your medical debt, really, it's not an indicator of your your credit score, because it's not something people choose to do. And the third big thing the bill does, it eliminates the automatic transfer of medical debt from one spouse to another, which again, on its face, this sounds like, is that really a thing that happened? Yes, it was. Minnesota was one of the few states that had this, and it was in statute that just automatically one spouse was responsible for the medical debt of the other spouse. And I'll note that medical debt was the only debt that was treated this way. No other debt was treated this way, solely medical debt. And so we eliminated that it's not just that automatic transfer that you are automatically responsible for your spouse's medical debt. So those are the three main biggest things. I will name a few other ones that are included. It establishes some new medical debt collection rights that are enforceable by the Attorney General, including a private right of action. It shifts some attorney fees in favor, which help Minnesotans if they are having litigation with these types of things. And so it allows more enforcement from the Attorney General's office, which will be useful in these cases. It requires that Minnesotans who successfully defend medical debt collection lawsuits have to be paid their attorney's fees. Before this law, it went the other way. If they lost, they had to pay the attorney's fees the other way. So this evens the playing field. It also requires medical providers to publish their medical debt collection practices. It just adds a layer of transparency, which is just helpful for people to know. It should be clear and transparent what those practices are. And the last thing I'll mention is that it relates to errors, miscoding. Again, we heard really awful stories from Minnesotans who ended up with giant medical bills for care that they didn't even receive. It was miscoded. It was an error, not an error of their own, but by the insurance company or by the facility. And because of that error, and one number got flipped or a miscoding, they ended up with a giant bill. And so this bill, this legislation, holds people harmless for those errors and does not allow collection of debt of bills until errors are worked out, until it is agreed upon by everyone that yes, this is an accurate bill. And so a number of pieces really intended to protect Minnesotans, to sort of add some fairness into that system and level the playing field. Again, knowing that this is not going to solve the entire problem of medical debt in our country, in our state, but will make a difference for Minnesotans. So you could flip to the next slide. This is just a picture of the bill signing. I will say this was very much a team effort. So I mentioned myself and my partner in the House and the Attorney General's office, but a number of advocacy organizations, because it was a package bill. We went through a number of committee stops. And so there were folks that told their really heartbreaking stories over and over again in committee after committee. And so I'm really grateful to the people who are willing to do that, to tell their stories over and over again and answer questions. And we had press conferences, we had, days of action. It was a big lift. We had countless hours of collaborative meetings with stakeholders to really get to a place of compromise. The bill didn't end up the way we introduced it, and that's okay. That's part of the legislative process. But really having those meetings with stakeholders to come to a place where everybody was at least neutral, if not fully supportive of where we landed. And there's more to do, and we'll keep working on it, but really proud of the work that we did do. And I think the next slide is the last one. So I will end there. Happy to take questions. My email is there. Happy to answer, in future, if you think of things, I'm happy to have people reach out to me as well.
Excellent. Thank you very much, Senator Bolden, for that comprehensive overview of Minnesota's holistic legislative response to the medical debt crisis. As you said, medical debt is not something we choose. It is something that happens. And the protections that you laid out will truly go a long way in supporting Minnesotans and allowing them to focus on that healing and recovery. So next up, I am going to go ahead and turn the virtual mic over to State Representative Lisa Reynolds for that overview of HB 3320.
Hello, everyone. Good afternoon. Happy to be here. And do I change the slides, or do you guys do that for me?
Yes, I will advance. So just
Awesome. I appreciate that. Okay. I should have been. Yeah. And thank you, Senator Bolden. Great program. And I did see Joseph Sparks' comment in the chat, which hopefully we can get into later. This is playing around the edges until we have real healthcare reform. Anyway, my name is Lisa Reynolds, and I am a pediatrician, and I'm a state representative from just outside the Portland area in Oregon. And I'm in my second term. And I ran for office, probably not unlike Senator Bolden, seeing what works and doesn't work for patients in my exam room. And I'm here today to talk about House Bill 3320, which is a bill I was honored to introduce and be a chief sponsor of in the 2023 session, intended to strengthen Oregon's charity care or the hospital financial assistance laws, which seeks to expand access to free or reduced care, and also to reduce predatory medical debt collections. So next slide. I don't necessarily have to reiterate what I think you all know what the issue is, right? That federal law exempts nonprofit hospitals. I feel like saying that with air quotes around it. Nonprofit hospitals, that's again a whole other topic, from paying any taxes. So it's a very lucrative benefit, and it's done with a nod towards acknowledging that these hospitals can or should be providing free and reduced cost care for patients who cannot afford to pay. One health system, which I'll be talking about today, Providence Health and Services, avoids paying $1 billion a year in the Pacific Northwest. Thanks for this exemption. So because the federal law is a little vague on what this means in terms of providing free and reduced cost care, several states had passed some state level charity care laws in order to try to give more detail and guidance. But we were finding that overall, a lot of the hospital systems were finding sneaky ways to thwart what I think of as a compact, by either not informing patients of such programs, by charging them anyway, and then by pressuring them into paying. In fact, in Oregon, there's only one single hospital that was found to be fully in compliance with the spirit and the letter of the law, and that is Oregon Health and Sciences University, which is a partially publicly owned hospital system in Portland. So slide 3, getting back to Providence Health and Services, it actually a pretty easy foil to have in this work. In the fall of 2022, the New York Times investigation kind of revealed some really predatory practices that the health system was implementing, there's something called the Rev Up system, which was basically to hound and pressure needy patients into paying for care that the hospital was supposed to provide for free. So it required staff to demand payment up front, not to ask about the patient's ability to pay. They skipped over the charity care options, and then they would send debt collectors and even take patients to court, indigent patients. The articles and actually a follow-up daily podcast. The New York Times has a daily podcast, I think in January of 23, they highlighted this. And it was just basically harassing and terrifying our low-income patients, and then impacted their comfort with seeking healthcare in the future. And it worked, right? Providence's expenditure on charity care as a percentage of their total expenditures decreased by over a third under this program, right? In direct contradiction. And attorneys general in Washington and Oregon and others have filed lawsuits against Providence. I think it was the Washington State Attorney General's lawsuit that kind of prompted the New York Times investigation. I remember the exact moment I read this article. It was a Sunday morning, although it was online. It wasn't the good, thick Sunday New York Times. And I just got this pit in my stomach. And I'm thinking, these are my patients' parents. And I say that instead of my patients because I just want to shout out that Oregon covers all kids. So I have no uninsured patients in any case. But these are my patients' parents. These are my constituents. And then I got mad and I reached for the phone, which maybe isn't always a great combination. But I tweeted something like, I tried to find my tweet and I couldn't. Something like, shame on Providence health systems for going after our neediest neighbors while they're supposed to be helping them. And I will say, and I'm curious what Senator Bolton found in this work. I had a few legislative colleagues, who are on the healthcare committee reach out to me like, wow, oof, that's pretty bold. That's pretty strong language calling out Providence. And I'm a little bit like, yeah, either you're a little weak or I'm being foolish. I did not feel like I was being foolish. And then I heard from SEIU, which is a strong labor union here in Oregon and probably in most states. And they asked me, hey, Rep. Reynolds, do you want to help hold Providence and others accountable? And of course, I was absolutely yes. And it should be noted that it's not just the spirit of the law. We think that Providence probably broke existing laws. And so that's all being worked out through the Attorney General lawsuit. So I decided to work with SEIU to tighten Oregon's laws so that there could be no more skirting of this issue. So if we could go to the next slide. So comes House Bill 3320. And again, this is in 2023. We decided not to reinvent wheels or come up with a whole new system of delivery or payment, or it was simply, we wanted to make our current system actually work as intended and to reduce the unfair medical debt. And like I said, SEIU were partners all the way. They did a lot of the work. It's one of those things, as politicians, we will say, like, if you build the parade, we'll come lead it. SEIU worked really hard on this. I was certainly in the meetings with all of the players, but SEIU took a real leadership role, not just in helping craft the legislation and find compromise, but they're really popular in the Capitol. They spent a lot of time talking to other legislators about this bill, and really helped get it over the finish line. Providence, I will tell you, was very anxious to be involved, to be seen as at the table, willing to support the measures. They were embarrassed and chagrined, I think more by the coverage than by the program. One of their lobbyists, who I really admire, tried to pawn this off as a few bad actors, right, at Providence, instead of the truly systematic attempt to fleece their poor patients. So as you can see, no love lost between me and Providence. On slide 5, so here's what the bill does. It works to improve access to charity care and financial assistance through a few simple requirements, right? Basically, let patients know what their rights are. So they're required to make the information on financial assistance readily available and super obvious for patients. It was sometimes the fine line on a billing statement, right? Now it needs to be prominently displayed on home pages of their website and on any billing or account information pages. Patients now can apply online for financial assistance, as well as through traditional methods like paper or even fax. In the past, it was a convoluted, outdated, cumbersome system to apply for aid. And so people kind of gave up. So they need to streamline that process. And this is a big one. Hospitals now must screen patients at point of service for presumptive eligibility when they're uninsured, or if they're in Medicaid, or if they already owe the hospital some money. So they don't even have to apply anymore. The hospital's kind of doing it for them. And there's this presumed eligibility. And if a patient has already paid and found to be retroactively eligible, the hospital needs to refund them promptly. And I think there's some fines for some of that as well. And of course, there needs to be an appeals process for patients who feel that they've been inappropriately deemed ineligible for the financial assistance. Next slide. We also are asking for annual reporting on how the system is working, right? So kind of the back end. And they must report how many applications were received, how many people qualified, how many were sent to collections, and how many were taken to court. And so while we are not setting out numbers, we're allowing to keep an eye on the hospitals and to evaluate outliers or what the trends are. I really believe sunlight is the best disinfectant, and this bill brought some sunlight to the previously dark and murky and diabolically complicated system of the hospital financial assistance. Next slide. This became a very popular bill, in part thanks to SEIU, which to be honest, SEIU tends to be seen as kind of, fans of the Democrats, but the Republicans rose to the occasion very quickly. They just had to hear a few stories, and we sure brought the stories to committee hearings and referred or repeated some stories on floor speeches and in conference rooms. It passed the House Healthcare Committee unanimously. It passed resoundingly on the House floor. It passed the Senate Health Committee unanimously. It passed resoundingly on the Senate floor, and then, of course, was signed by the governor. But we had a really wide range of support. So that's the bill went into effect this year on January 1st. And with the some final provisions around the appeals process, the patient appeals process will not be going into effect until January 1st of 2025. We don't know yet how it's working, right? We're just about 6 months into it, but we are watching. And we just want to make sure that hospitals held up their end of the social contract. And again, it's a whole other conversation whether there should be, whether this whole idea of nonprofit hospitals is an idea whose time has passed. But for now, we are really hopeful and optimistic that this will help alleviate the burden of unfair medical debt. And if it doesn't, we'll be back, with perhaps more sticks, so to speak. So that's what I have to say at this point. And I'm really grateful to be here with this amazing group of people who really care about this important topic.
Thank you very, very much, Representative Reynolds. I love that quote. The concept of sunlight is the best disinfectant. That is certainly a gem. And I also want to thank you for highlighting and underscoring some of the really harmful business practices that have been exemplified by nonprofit hospitals and providers across the nation. It is certainly an area that CAP has done quite a bit of research into, ensuring that behavior is under additional scrutiny at both the federal and state level. So we in the policy community will be continuing to monitor Oregon's progress and success. And I am encouraged by the fact that you're saying if these interventions don't get the job done, you are more than willing to come back and try again. So thank you for that. Next, I am going to go ahead and turn our virtual microphone over to Bernita Haynes from the National Consumer Law Center. Bernita?
Hi, everyone, and thank you so much for having me here today. I am Bernita Haynes. I'm a senior attorney at National Consumer Law Center based in Atlanta, although we're headquartered in Boston. I will be speaking very briefly about our Model Medical Debt Protection Act and providing just a general summary of what's included in that act. Next slide. Just very quickly about NCLC, we've been around since 1969, working for consumer justice and economic security with a focus on low-income folks and disadvantaged groups around the country. Next slide. Just a little bit about me with some hyperlinks, and if these slides are available, you should be able to click and see some of those documents linked. Next slide. Very quickly, a summary of what's in the Act and what I'll be talking about in this presentation. The Model Medical Debt Act addresses some of the following issues: financial assistance policy improvements, required steps before billing patients, underinsured patients, payment plans, debt collection protections, etc. Next slide. First, we're going to look at the overall purpose and some of the key terms and definitions in the Model Act. Next slide. So you'll see here, snippeted out, the general purpose of the Model Act is to reduce burdensome medical debt and to protect patients who are dealing with medical creditors, medical debt buyers, and medical debt collectors. This act and the language in it is meant to be construed very liberally by legislatures, so we want that kind of flexibility. Also, the act provides some guidance to the courts when the provisions are applied and interpreted. Next slide. You'll see here a few of the key terms used in this act. This is all listed here in Section 2. Most of these terms and the definitions are based on existing state and federal laws. For example, the definition of consumer reporting agency is based on the definition from the Federal Fair Credit Reporting Act. The definition of financial assistance policy is closely based on the definition promulgated by the IRS to implement the financial assistance provisions of the Affordable Care Act. Next slide. I want to draw your attention to one very important definition in the Model Act, and that is about large healthcare facility. So you'll see here a very concrete definition of what's meant by large healthcare facility. This definition also includes nursing homes, skilled nursing home facilities, rehabilitation hospitals, and similar facilities. The definition includes large group practices that might not otherwise fall into any other categories, but it doesn't include solo or smaller practices. We set a threshold of 20 million, which we think sufficiently defines a large group practice. I should also add that in addition to expanding the scope of the IRS's requirement to for-profit hospitals, as was mentioned, those requirements only relate to nonprofit hospitals under federal law. In addition to expanding these requirements for financial assistance to for-profit hospitals and other large providers, this definition also directs that any healthcare professional who provides services in a large healthcare facility has to also provide financial assistance and follow that facility's financial assistance policy. Next slide. So let's get on into a discussion of what the Model Act requires in terms of financial assistance. Next slide. So starting with Section 3, Section 3 states that large healthcare facilities must develop a financial assistance policy, and it lays out some of these minimum requirements that you see here. I want to emphasize that Section 3 notes that patients cannot be denied financial assistance on the basis of residency, health insurance, coverage status, citizenship, or immigration status, or assets and prospective assets. While the financial assistance requirements very closely mirror what's in the Affordable Care Act, it still, as noted, goes beyond the requirements in that law. These requirements apply to all large healthcare facilities and takes an additional step of setting forth some eligibility standards and minimum levels of financial assistance, which are absent in the Affordable Care Act. Section 3 also goes beyond the existing federal protections by preventing hospitals from limiting assistance based on stated class characteristics like residency and so forth, as noted. Next slide. Requirements around implementation are pretty straightforward, and I should emphasize that this law, this act, specifically mandates screening or presumptive eligibility. And during the Q&A, I can explain why that's so important. This section specifically notes that if a patient is uninsured, the hospital has to offer to screen that patient for public or private insurance eligibility and offer assistance to that patient if the patient wants to apply for said insurance. But if the patient refuses to be screened, that cannot be used as grounds to deny them financial assistance. The act goes into some pretty weedy details in terms of the income threshold minimum eligibility requirements. Again, the Affordable Care Act federal law doesn't state any specific income eligibility minimum threshold, so this goes beyond that. And also, it's very similar to a lot of state laws on financial assistance. Next slide. Section 4 also addresses medical debt collectors and notes that if a patient submits a financial assistance application to a medical debt collector, that collector has to then send that application to the healthcare facility within 2 business days. And also that debt collector has to stop any collection activity until notified by the healthcare facility of the outcome of that application, of any debt forgiven, of any new repayment terms. This section also establishes minimum requirements for payment plans, specifically prohibiting the charging of interest, late fees, and prepayment fees for any financial assistance eligible patients. Next slide. Regarding spreading information and education about the existence of the financial assistance policies, a lot of what's in this section is pretty in line with what we have in the Affordable Care Act. States can opt to use their own state law requirements or state guidelines for the format of notices from healthcare providers to patients, but this section is pretty similar to what's in the federal regulations. Next slide. Lastly, in the financial assistance section of the Model Act, there are some requirements around language access, which again is based on similar requirements found in the IRS regulations. Next slide. So let's look at some of the other provisions real quickly outside of financial assistance, specifically billing and collections rules and credit reporting. Next slide. Section 7 prohibits certain collection activities by medical creditors or medical debt collectors, noted here things like body attachment, liens against homes, and so forth. This section also requires that for large healthcare facilities, that billing and collection policies have to include and specifically spell out extraordinary collection actions that the hospital can take. We recommend that states consider broad financial protections that apply to a wider range of consumer debt. Detailed recommendations on that front can be found in our Model Family Financial Protection Act, which is available on our website and also linked in the Model Medical Debt Act. Next slide. Section 11 specifically bans the reporting of medical debt to a consumer reporting agency. Notably, I'm sure I don't tell anybody on this call, the CFPB has introduced rulemaking to ban medical debts from credit reports. We're supportive of that rulemaking and have steered a lot of that movement. Colorado has enacted a law that prohibits the reporting of medical debt to credit bureaus and the consideration of medical debt and a consumer's credit score. New York, similarly in 2023 passed that kind of legislation as well. Next slide. And looking at the last provisions in the Model Act, particularly around pricing, transparency, liability, etc. Next slide. So as you'll see here, some of the final sections relate to pricing transparency, financial responsibility for medical debt. I want to emphasize that among other things, Section 9 removes responsibility or liability for medical debt or nursing home debt from spouses or other family members and friends, and requires that any admission agreement into a nursing home comply with federal law, i.e. the Nursing Home Reform Act. Section 10 also sets forth what has to be included in an itemized bill. Very important itemized bills are, because they can help a patient understand what the healthcare costs are, whether some or all of the charges are covered by insurance, and whether the provider made any errors or upcharged. Next slide. Again, here you'll see some summaries of some of the concluding sections in the Act. Section 13, I should note that New York has capped interest on all consumer debt at 12%. This Section 13 is really necessary because in some states, post-judgment interest rates were passed during times of very high inflation, which means that in those states, they can allow as much as 12% interest on these debts, which will essentially double a person's debt after 5 years. So capping this interest rate is really important, and we've seen some states do this. Next slide. Again, a few other sections here looking at medical creditors and forgiveness of co-payments, etc. Next slide. And I want to conclude here with these few sections on waiving rights. Folks are not allowed to waive their rights under this act. Very importantly, section 21, the final section, addresses instances where a court strikes down the law or portion of it. In those situations, a severability clause will be, or may be needed anyway, to protect the rights established under this model act, even if one or more sections are still found to be valid. Next slide. I want to leave you here with some links to our various resources, including the Model Medical Debt Protection Act. All of these are available on our website at nclc.org. Next slide. And also leave you with my contact information. I can be reached very easily via email. And with that, I'll turn it back over to our lovely moderator.
Thank you very much, Bernita. That was an excellent overview of NCLC's model legislation. As we've discussed today, medical debt is clearly a crisis, but also a very complicated issue that has quite a few contributors. And really what struck me was the fact that this model act attempts to tackle nearly all of them. And so I definitely encourage today's attendees to follow up with Bernita and learn more about the fantastic work that NCLC is doing. With that in mind, I would like to invite all of today's presenters back to the virtual stage for the Q&A session of today's event. We've had some great interaction and questions pop up in the chat, and I want to be sure that we're able to get to as many of them as possible. And so I'd actually like to start with a question directed towards Senator Bolden. And so we had a question come in asking about how was Minnesota able to push against the powerful health industry to require hospitals to treat people who are in debt?
That's an excellent question. And I will say it was persistence and a lot of effort and teamwork. I sort of mentioned we had many hours of stakeholder meetings. It became clear from the start that we had to engage stakeholders. And so we met at least weekly, oftentimes a couple times a week throughout most of session. So for many months with that table, we invited essentially everyone to the table who wanted to be there: health plans, the hospital association, individual health clinics and hospitals and organizations, as well as our partners in the work, advocates, and of course the Attorney General's office, and then my partner in the House. And so part of that was just negotiation. Part of it was the push from the outside, the push from patients and Minnesotans who were demanding us to do something about this. It was, the stories that were told over and over and over from many, many people about the ways in which they had been harmed. It was difficult to argue against some of those heartbreaking stories. And the last thing I'll say is just Rep. Reier and I holding the line. That was one of the pieces that we said that this is non-negotiable. We will not allow people to be denied care solely because of a debt. And so, we said we can negotiate other things, but we're not giving on that one. That is going to happen. And so it was a combination of all those things, but great question, because it's not easy.
Thank you, Senator Bolden. Next up, there is a question for Representative Reynolds. Can you speak more on how charity care functions? Do these entities still get a write-off on taxes for having this pool of charity care, even if it isn't used?
Thanks for that question. I'm not an expert on it, but my understanding is yes, that they don't necessarily, they're not necessarily held super accountable on this. One of the things that I find particularly egregious is that a big chunk of their charity care is the amount that they get reimbursed from Medicaid and Medicare, and the gap that is between what they get reimbursed by private insurers. So I find that's that's creative accounting. And as a pediatrician, right, who 25% Medicaid, I don't have Medicare because I don't take care of older people. I have a couple Medicare patients who are disabled, but we don't get any extra credit, right, or extra gap for that. So, but my understanding is they have not been, there's not been an unrolling of their tax exempt status in any way. If they don't fulfill their full commitment. If someone else knows better, let me know. But I do think, I'm alluding to, we need to get rid of the whole tax exempt hospital thing to begin with. And, but apparently that has been, my understanding is I've had predecessors tilt at windmills on this, and that's very challenging. They're obviously an incredibly powerful and wealthy force.
Thank you, Representative Reynolds. Bernita, the next question is for you. And in regards to the Model Medical Debt Act, if a person has health insurance and the insurance company refused to pay, is there any type of mechanism to check, if the insurance company should have paid, and can they be forced to pay? So I think a broader question even around, what is the ability of this act to kind of address some of the somewhat common industry practices by insurance around, denying coverage or not paying for care?
Yes, that's a really great question. I will just first emphasize that this act is really more so focused on the hospitals and the providers, and doesn't necessarily focus on the insurance providers. That said, in situations like that, then it is very important for an individual who is applying for financial assistance or looking for financial assistance to make sure that they apply this act. As noted, doesn't just pertain to folks who lack health insurance. It's also very specifically targeted to folks who are underinsured as well. So in that kind of example that was mentioned, that sounds like a situation where potentially the individual is underinsured, where financial assistance should be made available to them. And then at that point, it'll just depend on their income and so forth.
Thanks, Bernita. And it looks like there's one additional follow-up question on the Model Act. So can you speak to just the general momentum around, states leveraging the act for their upcoming legislative sessions, or even previously, if you could speak to some of the states that have been, large successes or, kind of frequent adopters of portions of the act or the act in its entirety?
Yeah, really great question. I wish I had a running list of states that have actually adopted all, some of our provisions. I can definitely tell you some of the most recent ones. But before I do that, yes, there is a decent amount of momentum in terms of adopting some of the provisions in this act, particularly around financial assistance and so forth. I think it was in 2023, Delaware reached out to us with an interest in adopting aspects of this act, specifically related to, I believe, capping interest on medical debts, as well as improving financial assistance requirements in that state. We've had other states recently, such as North Carolina, that has essentially modeled their Medical Debt De-Weaponization Act, which you may be familiar with, off of our Model Act. It was initially introduced in 2022, I believe, and has been reintroduced this year in their session. Those are not the only two states. I would strongly suggest that folks take a look at our short report called An Ounce of Prevention, where we actually lay out the various hospital financial assistance policies around the country. And you can see there some of the states that have made strides to adopt some of the provisions of our act. But Delaware, North Carolina in progress, New York, Maryland, Illinois, there's a lot of momentum.
Great. Thank you, Bernita. And the next question I'd actually would love to pose to all three of today's dynamic presenters. And it is actually in regards to something that hasn't necessarily come up a whole lot, but is, a kind of emerging action that some municipalities and states have taken. And that is actually kind of buying and discharging medical debt. And so, these many jurisdictions have partnered with organizations like Undo Medical Debt, formerly RIP Medical Debt. And these partnerships, I've noticed, have really underscored just how disconnected healthcare costs are from healthcare prices. And so I know that recently New York City had spent about $18 million to cancel $2 billion worth of medical debt. So would love to hear from you all on the role that you see debt cancellation programs playing in alleviating existing medical debt for consumers across the country. So whoever would like to kick things off. Go ahead, Representative Reynolds.
I mean, yes. I mean, one of my biggest, there's a little sticky note on my desk, end poverty, right? And I've kind of focused a little bit more on child poverty right now as a pediatrician and in the 0 to 5 space. But we know that medical debt is what a burden it is for families and their financial future. So I would love to do that. It's obviously a challenging fiscal environment in Oregon to do that, but it is definitely something we are considering.
I will just chime in to say, similar. Yes, it's excellent. Again, one piece of the puzzle. It doesn't solve the broader issues that we need to keep working on, but does directly help people. It actually is something that I am seriously looking at for our upcoming next session in 2025. I'll note the city of St. Paul has done quite a bit of this with some one-time COVID dollars that they got. That's one thing they use those for, which is, in my view, an excellent use of those one-time dollars. And so absolutely, we'll continue to look at that.
Yeah, and I'll just jump in and add that we are strongly supportive of this particular kind of direct action that definitely immediately helps a lot of folks. We also, however, emphasize the extreme importance of upstream changes that can prevent the medical debt in the first place. The last thing, we want to see is more people sort of struggling with medical debt and dealing with these consequences such as wage garnishment and liens on their homes. And then finally, after dealing with all those consequences, they get some relief by having their debt canceled. We would love to see people never have to deal with those kinds of consequences in the first place. So we're supportive, but we make sure that we emphasize the upstream preventative measures are key.
Thank you for that input. And another question for all three of you. I think holistically, we heard today that there are kind of gaps in federal policy that, allows these loopholes for say, nonprofit entities to act unscrupulously. But conversely, there's also been quite a bit of federal action as of late by CFPB and other entities to try and address medical debt. So we'd love to hear from you all on how do you think state policies kind of complement or enhance these recent federal initiatives to provide a more comprehensive approach to alleviating medical debt? And are there additional areas of opportunity that states can pursue that we didn't talk about today?
I'll jump in and just very quickly say that one of my colleagues likes to refer to this as a belts and suspenders approach, I believe. She strongly supports the idea that we need to be, pushing for these federal changes, but at the same time, really advocating for states to do similar things as a way of supporting and bolstering the changes to further make sure that those changes actually happen at the federal level. So one thing in terms of credit reporting and the recent CFPB movement there, we've been strongly supporting states and advocating for states to actually pass their own bans on medical debt credit reporting as a way to really bolster more activity at the state level and to further at the federal level and to really support what CFPB and the federal government does. And in case that federal legislation that we want to see in other areas never happens, in case that rule never passes, we then have state protections. So I think it's very important for states to always be trying to think ahead of what the federal government is doing to protect their residents.
I'll just chime in to say, yeah, agree with that. I think there definitely, there is a role for policy work at the federal level and certainly a role for policy work at the state level. And they really, sometimes they overlap, sometimes they complement each other. Sometimes one, fills in the gaps of where there are, from the other. There's a role for both. And certainly, at the federal level, things seem to be, in flux at certain times. There's varying degrees and levels of productivity at the federal level and action. And so there absolutely is a role for states to play. To the question of like what comes next, what else needs to happen. Personally, I'm a firm believer in, healthcare should not be a space that is profit driven. That is just fundamentally wrong in my view. So a lot of my work is aimed at really sort of changing that paradigm and taking the profit out of healthcare. A long way to go till we get to that point. But also, I think about the increased corporatization and consolidation we're seeing in healthcare and how that really harms patients. And that is connected, right? Like that's because those entities are trying to drive their profits up. And that's what happens. That's the outcome of it. And what that means is less care for patients. And, in Minnesota, we have a lot of rural areas that are healthcare deserts. People driving 5 hours to have a baby, like that is just not what should happen in our country. And so I think we also need to really be looking at policies around that consolidation, corporatization, monopolization, and profit-driven healthcare system.
Representative Reynolds, anything you'd like to add?
Well, really well said, Senator Bolden. I totally agree. I will just share that we didn't talk about pharmaceuticals, but there's a push on the weight loss drugs, $1,300 a month. I mean, it's shocking, and I've been super frustrated with the manufacturers of those meds who are it's a profit grab. They talk about research and development. We know they reimburse themselves for research and development many doses ago. And states are, really worried about becoming bankrupt if they're going to cover these meds. North Carolina has just said we can't cover them anymore. Now anyway, so the pharmacy benefit managers are part of that process. So I just feel like there's so many root causes. We need to pull out those roots. And I almost feel like if smart people were to design our healthcare system, it would look nothing like how we're doing it now. But so root causes, which a lot of people in the chat or the Q&A alluded to, that's a long battle against very moneyed interests.
Indeed. Yes, there is so much work to be done, but I see we are at the top of the hour. So I want to again thank Representative Reynolds, State Senator Bolden, as well as Bernita Haynes. Really appreciate your time and expertise today, as well as all of our attendees for joining and being such active participants in today's discussion. Thanks for joining, and I encourage everyone to join us for the final session in the series, which is going to be Thursday, August 15th, and it is going to be focused on state policy efforts to limit prior authorization and claims denials. So hope you can join us for that, and enjoy the rest of your day, everyone. Thanks.
Thank you.
Thanks again.
That was fun. Yeah, thank you.